It is really a great pleasure and honor for me to welcome and introduce my friend and colleague. I think I say friend first because that is the case, Dr. Colin Scher, who many of you know from previous conferences. Colin is originally from South Africa. You've heard his past history. I'm not going to embarrass him any more than I have in the past. Colin has literally looked through the eyes of more children with Jacobson syndrome than any other person in the world. And, all right, I won't embarrass you anymore, but I do have a little token of appreciation from the Sulpizio family who have donated from their private vineyard wine for all the speakers, so make sure you get that on your way out.
Good call.
And, again, thank you, and it's really a great honor and pleasure, Colin, to have you here. I'll get out of your way eventually. Okay, and you know how to use that, and the mic is there, so you have to kind of stay close to it. It's pretty limited in terms of its range.
Good morning, everybody. Thank you, Paul, for being a friend, and also for setting up this conference so often. I think now I have a chance of beating him at tennis. Before this, it would never have happened. So what I'm going to talk about is a group of principles that affect visual development for all children, so that you are reminded of what's supposed to happen and when, what treatment modalities we have for various issues. But I think the greatest value from the talk would be if we have participation from you people. You are living with children who have eye issues all the time, and if you can ask questions, they probably will be germane to everyone sitting in this room. And from that, we can go deeper into detail about specific examples that affect your children. So is that that's gonna work? Yeah, better, because that's how it's set up. Okay. So what we're going to talk about is how Jacobson syndrome affects and the eye. Okay. So the principles of visual development are as follows. There are basically 4 important stages. The first stage is from birth until 8 weeks of age. Now, most of you don't have newborns anymore, but if you remember, if you take a full-term baby at week 40, they have about 8 weeks to develop formed visual images on their retinas. That means if anything is in the way, like a droopy eyelid, a cloudy cornea, or a cataract, they will not develop central vision in that eye or the eyes until the offending blockages are removed. So that's why we do need to look early at eyes for all babies. The next phase is the phase from 8 weeks of age to 6 months of age. And that's the time in which impressive central vision develops, color vision develops, and they begin to develop depth perception. And from 6 months until 2 years is when depth perception has to seal in. And if one does not have straight eyes by the 2nd birthday, then it's very unlikely that the child will develop true depth perception. They can develop forms of depth perception where they just learn from experience where things are in space, but measurable depth perception on a stereopsis chart needs to be acquired by the 2nd birthday. And the visual pathway continues to develop until 9 years of age. At 9 years of age, the visual pathway is essentially sealed into place. What does that mean? It means that if one has to use glasses, patching, or other forms of therapy to stimulate the vision on one side or both sides, it needs to be all done by the 9th birthday. What one has at the 9th birthday is what one will remain with. On the one hand, one will not lose any vision without treatment after the 9th birthday, but one will not gain vision with treatment after the 9th birthday. Glasses can change, alignment can change, but actual visual acuity is sealed in place by the 9th birthday. Now, when we evaluate babies, children, toddlers, etc., we have goals, and the goals are we want by the 9th birthday to have the best possible visual acuity for that particular child's visual potential. We want them to have normal eye structure, if possible. If we want to put their eyelids into the appropriate position, we want to have the cataracts removed, any structural issues need to be fixed. We also want the best possible binocularity. That means the eyes need to be straight as early as possible, and we need to augment the alignment with glasses and patching to make sure that that binocularity is maintained, enhanced, and reaches its full potential. Akin to that is having cosmesis. If the eyes are straight and seeing well, the child will also look normal to the world. It's more important that the child sees the world normally, but it's also important that the child is seen by peers and later on in life as someone with straight eyes, because in the Western culture, having straight eyes is an important statement about the person's ability to make eye contact, and it's almost like if you can't meet someone's gaze with both eyes, then you might appear to be furtive or untrustworthy. And we see a lot of adults who come in with that exact story. I say, my eyes have been turned since I was 17. I can't get a job. No one talks to me at work. I can't. When I'm in a bar, people move to the opposite side, and so on. And then one wants to integrate the visual system with the central nervous system and learning, because if you have straight eyes, equal vision, good binocularity, and the eyes are well integrated with coordination, fine motor coordination, gross motor, and visual integration of information, then obviously you're going to have a very high functioning system. And it behooves us to have children seeing as well as possible, because the other systems will drive off good vision. Sometimes one doesn't have an option. Sometimes a child is really severely visually handicapped, and they might need to find other ways of learning. But it's amazing how resilient they can be, even with poor vision or no vision at all. Now, all babies should be evaluated at birth for what's called the red reflex, to make sure there's nothing obstructing the light going into the back of the eye. If there are no concerns before that time, they should be seen before age 6 months in an ideal world, because you want to get the binocular system going as early as possible. If there's no problem with it, seeing the child every 2 or 3 years after that is fine. But if there is an issue, you want to pick it up as early as possible so the intervention can get the system onto the right track. What do we do when we do these exams? Obviously, in your specific situation, we know what's going on. We know that there's a long list of associations with Jacobs syndrome that are found in the eye, and we know what to look for. But in a generic sense, you take a family and personal history of the child. You then measure the visual acuity, and one can do that in a nonverbal child very easily. You can tell if both eyes are working well, or even if there is a preference for one eye over the other. Alignment, we look at the lids and the orbits, and then we go deeper into the eye. We check the pupils, the anterior segment, which is the cornea, the iris, and the lens. We then go backwards into the optic nerve and the retina, and to do that we need to dilate the pupils. And at the same time, because of the pupils are dilated, you can get what's called a cycloplegic refraction. You can determine what the focusing requirements are for each eye separately, because one of the most common forms of amblyopia, lazy eye, an eye that doesn't work well, is that both eyes look normal and appear straight, but that the quality of the image going into an eye with a high degree of astigmatism or farsightedness compared to its fellow eye is not the same quality as an eye that does not have those challenges. And that's why cycloplegic refractions are very important in the first few years of life. Now, in principle, if you have a child with an eye problem, we have a list of options that are open to us, and the menu of options, we do select the appropriate items that work in a particular situation. So in principle, we use glasses if there's a refractive error, or if the eyes are crossed because of focusing, or if the eyes are not equally focused. We use patching if one eye remains weak despite the best pair of glasses. We do orthoptic therapy, which is a form of getting the eye muscles to work together in a healthier fashion to maintain alignment. Sometimes we do strabismus surgery if the conservative therapy fails. And we also often need to do TOSA surgery or cataract surgery. I need to say this because one doesn't want to be negative, but you will come across helpful people in your children's lives who want to do what's best for your children. Sometimes what happens is people mention stuff called vision therapy, and I'm here to tell you that until there is serious evidence that says vision therapy is effective, there are far better ways to spend family resources and, more important, your child's time in doing something else than vision therapy. Occupational therapy is wonderful, physical therapy is wonderful, gymnastics, playing soccer, swimming, arts and crafts. They do a lot of things for the eyes, but vision therapy is not known to do anything for the eyes. So if well-meaning people might recommend it, just be an educated consumer. Select things that are known to work. When we do start managing an eye problem, we have to be on a team. The physician is an important piece of the puzzle, but we actually see the child maybe three or four times a year, and then we leave you with a lot of instructions that need to be done by the family at home. That includes using the glasses, doing the patching, coming back for follow-up, using drops, whatever. We need, in the office, we have our technicians, we have our orthoptist, and we have an optician to make the glasses. At home, we need the family. We need the teachers to be involved in the situation because their feedback is very important. And often, the occupational and physical therapists will also help to integrate the visual system into the appropriate functioning of the other systems as well. So that summarizes what we can do and when it should be done and how we do it. I want to thank Paul again. I want to thank you guys for coming in because you're a pretty wonderful group of people actually. And I'll take whatever. I have time for questions, and we'll try and use those to explain how things could or should be managed. But it's always easy to be an expert standing up here. I don't want to second guess, the people who are working hard with your children at home, but I will try and offer some guidance. Yes, ma'am.
Everybody make sure to go to the microphones to ask questions, and then Tim and Sydney, or Tim, let us know if obviously there are any live stream questions.
I have a daughter who's 26 years old now. Had the pleasure of meeting you when you came to the first conference with us, and you did her examination then. Since then, she's continued on with care. One of the problems that we have that is ongoing is the fact that how the eyelids don't close completely, and so she's getting the dry areas, and so we've been supplementing that with drops and then the thicker gel or the lubricant at night. How significant is that situation? If those corrections weren't made by the time 9 years old comes around, to their vision, ongoing.
Okay. So the question is, if someone has inadequate eyelid closure at night and the cornea becomes exposed because the lids are not closing and you're not blinking, that condition is called lag ophthalmos. It means the eyelids don't get where they need to go. So it is important, and you're doing the right thing. One does want to use some artificial tears during the day, but that's not usually when the issue is. The issue is usually at night. And one wants to use a good ophthalmic lubricant. That really helps a lot. But what also helps is to use those, those nasal strips that you use to open the nostrils of, say, someone who's snoring, or if you're a racehorse and you want to run faster. Those nasal,
For 2 races.
Yeah. So what you can do with that is you can put one on the upper lid, the edge of the sticky part on the upper lid, then pull it quite tight and put the other one onto the cheek. And that will keep the eyelid closed at night. And it's actually very effective. So I would put the ointment in, then I would put the little strip on, and then you're good to go. And that's actually a very good way to go. If that fails, if the cornea becomes dried out, scarred, and infected, then one has to do a tosorrhaphy. You have to sew the eyelids together at the outer edge. But using the nasal strip actually avoids that. Yeah.
Hi, thank you for being.
Just hold it. My son had the surgery for strabismus at 1, but it did not completely correct the problem. And his doctor was honest and explained to me the problems in the brain, that this will have limited success. My question is, how often do you think will he need the surgery again? I'm really afraid of him losing vision in one of his eyes. And throughout his eye exams, his doctor has said that his vision is remarkable considering that he has strabismus. And there are times when he focuses on me, but most often he doesn't. And do you think he should have another surgery? Is it something that like every few years I should expect it?
Okay. So, one, the fact that he sees equally out of both eyes is great. You're taking him back for checkups, that's very important. And so it depends really on the amount of time that his eye is deviated on any particular day. And I would say that if it's well controlled 80% of the time, 90% of the time, I wouldn't rush. But if it starts deviating more and more each day and he's losing control, there's no harm in doing a second surgery. Under the best of circumstances, one can never guarantee that one surgery will work. And in the best of circumstances, without any underlying issues, we might say there's an 80 or 85% chance of a single surgery doing the job. So your doctor was honest with you, and I think it sounds like you're seeing someone who's really on top of it. So I would say keep following, keep staying with them. How old is your son? 8. Okay. So just basically keep a trend line. Do his eyes go in or out?
Out.
Okay. So is he doing exercises, convergence exercises?
No, we haven't.
Okay, so ask your doctor about doing convergence exercises. Convergence exercises, what they do is as you bring something close towards you, your eyes tend to go this way. So you're building up the inside muscles, the medial rectus muscles, which stop the outside muscles from dragging the eye to the outside. That condition, the outward drift, usually becomes worse in the summertime, because they're doing much less schoolwork, much less homework, so they in a much more distant situation. They're outside, they're at the swimming pool, they're in the fresh air, and that's when your outer muscles tend to dominate. So the drifting is often worse in the summertime. So if your child's into reading, some extra reading through the summer will help everything, the academics next year and also the alignment. But as he's reading, ask him to slowly bring the book towards his nose until it gets blurry, then quickly reposition it once it gets blurry and read again on the way in. And that will really help these inside muscles. So I would do that. Okay.
One more question, if that's okay. He also has ptosis.
Yeah.
And the doctor mentioned that, that might be an option for him. And at this point, it doesn't seem to be impeding his vision, so it would really be more of a cosmetic thing. But I worry about him being teased. And is that something? I was told that from other children who had this surgery, that kids with Jacobson syndrome, their eye muscles are much thinner. And so I guess let me ask you the risks. Do you think the risks outweigh the benefit if right now it's more of a cosmetic thing when we think about the breathing disorders and the fact that the muscles are different?
Right. So I agree with you. At this stage of the game, it's cosmetic. It's about self-esteem. I would speak to your ophthalmologist and see what he has to say. You probably could make it look a little better, but sometimes when the eye drifts to the outside, that can aggravate the ptosis because they tend to squint an eye as the eye goes out. And so the ptosis might be exaggerated because it might be more, there might be a basic ptosis, but there might be an extra component because of the drifting eye. So it might be a little bit more tricky than that. You don't want to overlift the lid. That's important. So I would try and synthesize what's going on here. Is it the ptosis alone? Is it the ptosis plus the strabismus? Should both be done at the same time? Should they be done at all? I think it's an ongoing conversation. But this, it becomes complex. And the person who's seen him a lot needs to answer those questions. And you should sit down for 20 minutes and discuss it with him. Yeah, at the next visit.
Thank you.
Sure.
I have two questions. The first one is, you made a list of things that should be checked during an eye exam, including the cycloplegic reaction, optic nerve and retina, and so on. Would most eye doctors do that when they're checking? Because I have a feeling my granddaughter might have a problem with some reading sometimes, but her acuity comes back normal.
Okay. Right, so you can have a normal acuity and still have a problem with sustained accommodation, which is reading up close. And you wouldn't pick that up with a cycloplegic refraction. You'd ask the child to pick up a book and read where it's comfortable and see how long they can do that for. If the child is stopping to read after 5 or 6 minutes, it could mean one of two things. It could mean that the accommodation, she's unable to keep the focus sustained for a long time up close. The answer to that is to use a bifocal, and that's quite okay to do that for academic purposes. Or it could be what's called convergence insufficiency, where the eye muscles don't keep the eyes looking at a near point for a long period of time, and that will get picked up during an eye exam. So it could be either...
If that's the case, is there anything you can do about that? Or?
The convergence insufficiency, yes, you can do exercises for that, convergence exercises, pretty similar to what I showed. Okay. But working with an orthoptist is the way to go there. An orthoptist, you'll find them in pediatric ophthalmology offices.
Okay.
And you want to be working with a pediatric ophthalmologist, not a general ophthalmologist or an optometrist. You want to work with a pediatric ophthalmologist.
Thank you.
Okay.
And my second question was, you mentioned that you don't really think that the vision therapy is that helpful.
That's not a personal opinion.
Okay. I guess
it's the opinion of the American Academy of Pediatrics and the American Academy of Ophthalmology.
Right.
And after looking at all the non-evidence that's available, because unfortunately there isn't any evidence to show that it works. Yeah.
But you also said there are other things that are more helpful. And one of them you mentioned was gymnastics, and I didn't quite catch some of the other ones, and I was wondering why would gymnastics be helpful?
Okay, so the point I was trying to make there, and forgive me for being obtuse, was if you have elective time in your child's busy schedule, and you want to spend an hour in a week doing something, choose something that's really useful, like gymnastics or sports or crafts or whatever. Don't waste it on vision therapy.
Okay, I thought you meant
vision. Right. Okay.
I have two questions. One, when you were going through the progression of the different the timetable of development, there you go. I had a question because one of the things, my daughter's 9 now, and one of the things that kind of came up with her because she has nystagmus was because she's cognitively delayed. Is that still a chronological as far as vision development, or what is your opinion?
Yes. So yes, I would say that as an average, most children's visual development reaches a standstill at age 9 years. What that means is that the visual pathway is now fully developed, fully mature, and is no longer responsive to patching therapy to make one side or the other stronger. With nystagmus, one can still change things. What one can do with nystagmus is to do surgery for nystagmus. Does she have a head turn or is her head straight?
Her head straight. Okay,
so if the head is straight, what one can do is disinsert and reattach the 4 horizontal rectus muscles, 2 on each side. And that can dampen the nystagmus somewhat and can improve the visual acuity by 2 or 3 lines, even at 9 years of age. Because very often children with nystagmus see better up close than they do at distance, because when you're up close, your medial rectus muscles are tighter, and that tends to dampen the nystagmus, and there's often a healthy disconnect between the distance vision and the near vision. They often do better at near, and sometimes one can get the near quality to become the distance quality by doing a nystagmus procedure. It's not sort of a panacea, but it can help by several lines.
My second question is, with the one of the things, she gets vision. She has a vision teacher at school. She goes to a special needs school, and one of the things that she doesn't do well with the depth perception, which we don't know because of the nystagmus, and she also has exotropia, is that we started to use a cane to get her to look down. And I was wondering if there's other things like that might help as far as helping the depth perception and getting maybe multiple sensations to help develop that.
I would say that if she has both exotropia and nystagmus, that really would be a good idea to have eye muscle surgery, because what that will do is it'll pull the eyes closer, but also it'll improve her peripheral vision, her depth of field peripherally, and that might really make a nice difference for her.
We did have the exotropia surgery, and unless she gets tired, the exotropia doesn't usually. But we haven't looked at the nystagmus surgery.
Okay. Well, if you've had exotropia surgery, then two muscles have been attached and reattached. So therefore, there are two other muscles that could be done. And doing that could be used to augment the partially corrected exotropia. The VH teachers, the visually handicapped teachers, are excellent. They have a lot of modalities that we probably haven't heard of to try and improve mobility and, environmental recognition skills in children who are visually handicapped. So it sounds like you're working with someone who knows what they're doing.
Thank you.
Okay.
Hi, my daughter is 2.5 now, and she doesn't have Jacobson's. She has an interstitial deletion, so it's a little bit different. And we originally knew something was wrong because she wasn't making eye contact. So she was diagnosed with delayed visual maturation, and she had gray optic nerves. And as her vision came in, she developed nystagmus and amblyopia, but both have resolved themselves. So now at 2.5, she wears glasses. And her vision is very different in both eyes. She's nearsighted, but one is far worse than the other. And the doctor also said she has a star-like pattern on her eyes, which is similar to like a Williams syndrome child. And I'm just wondering what that means. And also, should we expect her eyes to always be bad? Is it going to get worse? Could it possibly get better since the other things have gotten better?
Okay. So it sounds like a lot of things have gotten better, which is great.
Okay.
The nearsightedness is not going to get better, it's going to get worse. But that's okay. All nearsighted, if you are nearsighted, it means your eye is longer than it should be, from front to back. So as your child grows, her eyes are going to grow some too, and as the eyes lengthen, she will become more nearsighted. That's definitely that's cast in stone. That's why one doesn't do LASIK on children or teenagers. You have to wait until the eyes are fully grown, which is round about the mid-20s. So that's why you delay LASIK, because you don't want to do surgery on an evolving situation. You want to wait. So yeah, she will get a stronger prescription as time goes by. If she's able to, what will help her might be contact lenses at some point, because what that will do is that will improve her peripheral vision, because if you really are very nearsighted, the glasses are so distorting that you have a very narrow range of vision through the lens. If the lens is on your eye, then as you look from side to side, the central vision comes with you, and then you don't have the distortion that's caused by the lenses of the glass. So
will it ever kind of even out? Like by the time she's a teenager, will her prescription stop changing?
Well, when you say even out, I suppose you mean that one side is more nearsighted than the other.
Or just stop progressing and getting bad.
That will end probably in the mid-20s.
Okay.
Yeah. There's no way to stop that. That's just the way it is.
And then the star pattern?
Yeah, I'm not sure what he means by that. Does she have a slight cataract, or does she?
Doesn't, no.
Or does she have an irregular astigmatism? Is that?
That I don't know.
Okay, it could be that.
Okay.
That the cornea is somewhat distorted, and so when you do the retinoscopy, when you do the prescription, the retinoscope can distort into a star fashion. It's a star appearance, and that might be what he's talking about.
Okay.
Yeah.
Thank you.
Okay.
We have one question via the live stream. She has a 21-month-old son who has alternate divergent squint. The squint is quite large and has been told that he'll probably have 2 surgeries. He also has myopia in addition to strabismus and some ptosis, and wants to know when would be the best time to have the strabismus surgery.
Okay. If he has a consistent, measurable deviation, I would do it now. I wouldn't wait, because he's almost 2. He's almost reached the stage where the binocular window has closed. So they should do it quickly. Yeah. It doesn't matter if he's going to have 1 or more than 1. They should try and get him straight so that his eyes can start working together as a team. The ptosis, well, one doesn't want to do ptosis surgery until the child's at least 4 or 5 years old, because you need enough tissue to work with inside the lid. If the ptosis...
Speaking to the speaker.
Hello? No, is that... Okay. If the ptosis is completely obscuring the visual axis, that needs to be done right away. But if it's a slight ptosis or medium ptosis, that should be done at about age 4 or 5. If it's significant. Are we good? Great. Okay. Thank you.